Erickson. I'm Executive Director at Wisconsin Literacy, Wisconsin Health Literacy. Thank you for being here today. We are really pleased to have our panel here today from UW-Madison's All of Us Research and Community Engagement Program. We also want to give a moment to hear a little bit more about how All of Us works in communities all around Wisconsin as well. So we're glad to share that this plenary session is sponsored by the network of the National Library of Medicine, All of Us Community Engagement Center. And we're really happy to have Brittany Thomas here. She's the manager of the National Networks of Library of Medicine, All of Us Community Engagement Center, and it's out of the University of Iowa. And she's with us to share a bit about NNLM, the All of Us Community Engagement Center. And Brittany, again, thank you for NNLM's keynote sponsorship of this event. We're really, really pleased your engagement in health literacy over the years and working with Wisconsin Health Literacy. Brittany's going to share a little bit more about their work.
Thank you very much. Such a mouthful, NNLM, All of Us Community Engagement Center. And thank you all so much for coming, and we're really happy that you were able to be part of this presentation and just to be here. So hi everyone, my name is Brittany Thomas, and I promised 2 minutes, so I timed myself. I will not deviate, I promise. I just would like to share a little bit about the network of the National Library of Medicine and how we are partnering with the NIH All of Us Research Program. So first, what is the network of the National Library of Medicine, you might ask? It is the outreach and engagement arm of the National Library of Medicine, part of the National Institutes of Health and the world's largest biomedical library. And the mission of the network, or what we call NNLM for short, is twofold. First is to advance the progress of medicine and to improve public health by providing all U.S. health professionals with equal access to biomedical information. Second, and more importantly, in my opinion, it's to improve the public's access to information to enable them to make informed decisions about their health. We do this work through our large network, over 8,000 member organizations across the country, mostly libraries and other community-based organizations, and we support a highly trained workforce through this network that offers biomedical and health information resources and data. This workforce or this network also improves health literacy in their communities and increases health equity through access to information. NNLM has also been a partner of the NIH's All of Us Research Program since 2017, bringing awareness of the importance of diverse participation in biomedical research to communities who have been historically underrepresented in that research. We promote health literacy, digital literacy, and research literacy as essential tools for participating in that research and in supporting our community's health through community science. We support our mission through the network and our work with All of Us by offering funding, training, virtual programs, and other resources for libraries and other community-based organizations that they can use to further individual and communities' health, to build and strengthen partnerships with the communities who are underrepresented in biomedical research, and to raise awareness of the All of Us Research Program across the country. So no matter where in the United States you live or what organization you're with, it doesn't have to be a library. There are always opportunities to get involved in the health of your community by becoming an NNLM member if you aren't. We're excited to be here and are even more excited to talk to you about how you could get involved in this work and become an NNLM member. And so I am going to be here through the duration of the conference. We're going to snag a table up in the exhibit hall and have some brochures and pamphlets available for you. So if you see me, grab me. Please don't hesitate to stop by and chat. We're really happy to be here and looking forward to engaging with you all. So thank you.
Thank you, Brittany. We're very pleased to bring you the All of Us Research Program from the University of Wisconsin-Madison on advancing all of us recruitment and retention using community asset-based models to reach 1 million. So I'm really pleased to have our panelists here today, Gina Green-Harris, Bashir Easter, and a community partner, Pastor Clem Richardson, are going to share about the great work that they're doing out of UW-Madison, but over in Milwaukee area. So I'll start with the introduction for Gina. Gina Green Harris is the co-investigator for the University of Wisconsin-Madison All of Us Research Program, the inaugural director of the award-winning Center for Community Engagement and Health Partnerships, the regional office in Milwaukee. She oversees the UW All of Us Milwaukee team, which focuses on serving the underrepresented African American and Hispanic communities. Through the CCE, Ms. Green Harris also serves as the director of the Wisconsin Alzheimer's Institute, and as a champion of health equity, she helped create the CCEs to further advance research in the African American community in a culturally inclusive manner. Green Harris has participated in many research programs, received many awards, and has been appointed to various university and community committees. Most notably, she currently serves as the chair of the State of Wisconsin Governor's Health Equity Council and the National Institutes of Health Community Engagement, Recruitment, and Retention of Underrepresented Groups Steering Committee. She received her Master's of Business Administration from Franklin University in Columbus, Ohio, and her Bachelor's of Science at Central State University in Wilberforce, Ohio. And she is currently pursuing her doctoral degree in clinical investigations from the University of Wisconsin-Madison. A fun fact about Gina Green Harris is that
That wasn't fun enough.
that was a mouthful. But this is a little more fun. So she loves whale watching, but absolutely hates boats. So no matter the size. So every time she goes whale watching, she only sees dolphins, which isn't bad, but they're not whales. And because she can't stay out long enough for the whales to arrive. But that being said, she's going to attempt again this summer. She's headed to Alaska and is going to try it again. So
Better luck this time.
better luck. Yes. Okay. All right. Bashir Easter is the assistant director of the UW All of Us Research Program in Milwaukee and oversees the day-to-day operations of the UW All of Us Milwaukee team. And in 2020, he completed his doctoral research focusing on African American adolescents' internal and external experiences caring for a family member living with dementia. His interest in this topic is personal. He is the one in his family caring for his mother, who was diagnosed with dementia at the age of 55. Following this diagnosis, he intensified his research in the area and became the first dementia care specialist for the Milwaukee County Department on Aging, working with community partners to make a significant impact in creating a dementia-capable system and dementia-friendly community. Dr. Easter earned his Doctor of Philosophy from Capella University, a Master's of Business Administration from Concordia University, and a Bachelor of Science from Cardinal Stritch University. He also received an Associate of Science degree in Business Management from the Milwaukee Area Technical College. A fun fact, I love this one. Bashir loves watching Bigfoot shows, even if they continue to find nothing, right? And he just cannot wait for the next episode or the new show to happen. So joining the panel is Pastor Clem Richardson, who's a community partner to the All of Us Center for Community Engagement and Health Partnerships. And Ms. Harris will share a little bit more about Pastor Richardson's involvement with their program. Thank you.
Okay, can you guys hear me? Well, good morning.
Good morning.
Happy almost, Tuesday. Nowhere near Friday. And we don't want to go back to Monday. So I am just so honored to be here, and I believe our team, we are so honored to be here. We don't take this lightly. And for the record, I like to under-promise and over-deliver, so everything you heard, please forget about me. Don't listen to that till at the end. And so, Pastor Richardson,
Yes.
actually, I'm going to have you say a little bit about yourself. Is that all right? Can you do that real quickly?
I can. So, Pastor Clem Richardson, born and raised in Milwaukee, Wisconsin, have an associate degree in theology. Don't trip, I'm not going to preach. I do have a bachelor's in human services, a minor in social work. I'm a mental health professional, too, as well as a substance abuse counselor. And I just enrolled in a doctoral program for clinical supervision and education.
Woohoo.
So, yeah.
That's
Fun fact about me is I like martial arts. I practice martial arts, but I don't have a belt. So that's it.
Well, you about bad as me and Will watching.
Right, that's right.
We ain't getting nowhere. So work on us, you all. So it is indeed, again, an honor and a pleasure to be here. I'm going to get our presentation started. But before I do want to acknowledge our team members who are here. We have Dr. Leslie Maccabee, who is our You can stand up and let the people see you, girl. Now, Leslie just came to us from Nashville, y'all. This is her first Memphis. Oh, excuse me. Yeah, I am not. We're from Wisconsin, girl. It's all the same. And so, but we will say this is her first winter in Wisconsin. Give her a round of applause for staying. So we want to honor her. She has been a phenomenal team member and has just come in running. And then we want to acknowledge our our media guru and person who wrote those bios that Bashir and I were like, who wrote that? Yeah. And so Ms. Vivian King, and some of you may recognize Vivian. She used to be on news station TV4, Channel 4, NBC at home, and she's done all kind of worldwide stuff. We want to acknowledge her and thank her for her love and commitment to this work with the All of Us program as well. And then I do need to acknowledge one of our dear colleagues and partners in our work, Dr. Yinka. And yeah, I know, oh yeah, you got to stand up and say hello. She is actually a UW investigator. And so while we're going through this presentation, I want you to keep in mind that these are the folks that we work with. And I call you out too. You want me to call you out, Julie? Yes, go on and stand up, Julie. Go on. Julie's another partner that we have, and she works so closely with us, and so it's good to see you too. And so guess what, everyone? All of you are the most important people in the room too. So give yourselves a round of applause for showing up. I'm going to go ahead and get started here. What we want to do today is really just kind of share with you and talk with you about what we're doing in this model called asset-based. And really, at the end of the day, foundation, the purpose of it is to really build healthier communities with communities, not for them, not instead of them, not in lieu of them, but with them. So how many of you guys work in communities? So put those hands, it's okay. Oh, geez, come on. I know we're COVID, used to being in COVID, but can we just kind of pretend like we want to raise the roof a little bit? How many of you work in communities still, despite? All right, so then we're going to talk a little bit about what we can do to help us and then learn from each other, what you're doing, what's working, what may not be working, but we want to do that real quickly here. So you're going to hear from me, you're going to hear from Dr. Easter, and then you're going to hear from Pastor Clem as well. So the Center for Community Engagement Health Partnership is part of the Wisconsin IDEA. Our center is really focused on helping and working with UW leadership, faculty, staff, and the community to maintain and support and build culturally appropriate and competent and confident outreach, education, research programs so that we can have equity, that too, but equity for all Wisconsinites. Wouldn't that be ideal? And so that's really our mission. Our mission is to use the lens of the community to help our investigators better understand how to communicate, how to live with, how to play with, and actually how to get out of those ivory towers, if I might say it that way, to come and really understand what does the community want to see in research? What do they need to see to eliminate their own health disparities? How many times have we quoted statistics to community members, but we do so from a deficit, right? If you keep telling me I've got diabetes and you never bring a solution, well, what's the point in telling me I've got diabetes, right? The community is saying to us, we know our issues and our ailments, we know our illnesses, we're asking you for solutions and resolutions, and not for us, but with us. Make sense? So that's really what we do. So how do we actually do that, and why do we have this model? What makes this work? So again, our goal is improved community health outcomes through inclusive research. Say inclusive with me. Inclusive. That means including who? Everybody. You can say it with me. Come on, let's pretend. Okay? Inclusive means?
Everybody.
Right. So how do we do that? And this was a slide that we put together early on. There's some changes, but for the most part, it is the same. And I am going to be the first to say, so as much as I know how to talk really well, I am so technology challenged. So if I accidentally advance this slide when I'm trying to hit a red light or something, just forgive me. All right. And I'm trying to figure out, does anybody know how to make the red light work? The beam?
Middle.
No.
Familiar.
Yay, success! Small wins, small wins. And so basically what we want to do is improve health outcomes. How? The first thing we have to do is have some on-campus presence. That means really helping the investigators know that the center and the work that we're doing is genuine, it is authentic, it is credible. Why? Because how many of you know how many of you know academic institutions and investigators only believe each other? It's okay. Thank you for being honest. Is that Martha? Is that your name? See, Martha. Yes, thank you so much for being honest. So we know we have to have presence on campus. That came by committees, working in committees, having presentations with faculty and students, specifically about asset-based information, assets-based, talking about the strengths and the resilience of the community instead of deficit. Then we also had to have dialogues with investigators. You see that word, before they were engaging community members, right? Because we also know that once we get in the community and we start talking to folks and we come in with the incorrect language or we come in with an attitude, how many of you kind of white coat syndrome, Superman syndrome, we start coming in the communities at first, we miss opportunities. So we really try to talk to our investigators before they advance their work. So then we became a liaison between investigators and communities. Why? Because we are grassroots. We focus our efforts. Our motto has been since 2008, meet the people where they are. Meet the people where they are. And we have made an intentional effort to consistently listen before we respond. Listen before we do anything. And get the approval of the community as we're moving programs forward. Now, that doesn't mean we can do everything the community asks us to do, but what we will do effectively, we will do efficiently, and we will do so with the intent of making sure the community as whole get this when we're gone. The goal is that at the end of whatever we do, if we can never get another, Dr. Yinka never gets another grant, when she leaves the community, they ought to be able to continue to thrive. That's a nuance that we're working on, but we're doing it. So we guide the opportunities for language and dialogue in the community, meaning we're connecting these investigators with the community in an intentional way. So we bring the community into the room, we bring the investigators into the room, but we ask them all to take off their hats and be equal and consider each other partners versus here's the institution and here's the community. So we're working hard to do that as well. And then we establish these equitable partnerships and relationships that Dr. Easter's going to talk about here shortly. And what I say about that is that we have a comment that we use. We don't use contractual relationships all the time with our community. What we call our relationships are covenant relationships. And if you know anything about covenant relationships, they're built on trust, they're built on foundation, and they're built on longevity. They're not based on financial transactions. It's okay to laugh. It's all good. Y'all like this girl a mess. I'm going to be done in a few minutes. But it's not based on financial transactions. And that has been a huge problem with what has happened in times past. We come into the community, we say, hey, we'll give you $10,000 if you'll help us recruit. Well, you never even will recruit what? Or we just need warm bodies, so we'll give you some. No. Let's talk about what is it that the community really wants to focus on. What's your research question, community? That's where our community science comes in. How can we build stronger, ethical, and equitable relationships? And oh, by the way, we're investing in you, and we want you to at some point invest in us, but not financially. We're investing to understand what the problems are, and then we're going to work together to find credible solutions. Now, the accountability on us is to use our resources from the campus to help build the infrastructure that the community needs. The community's accountability is to make sure they show up, right? But only way to make sure they show up is what's the T word, everybody?
Together.
That's right. And we have to be trustworthy. If I say something to Pastor Clem, guess what? I sure better. Oh, let's try that one more time. If I say something to Pastor Clem, I need to make sure we do it.
Do it.
Even if we have to come back and apologize and say, hey, we didn't get it right, but we tried. We still have to be human and get it right. Got that? All right, I'm going to keep it moving. Next thing is we community led dialogues. So the community actually leads some of our dialogues, and then develop of the implementation of mutual benefit to research, and then integrated work. That's basically what we're doing with this program model. And then, so what is our partnerships with the All of Us Research Program? Basically, we want to make sure that the Center for Community Engagement Health Partnership is having successful initiatives that are inclusive of African Americans, Latinx populations, and those other marginalized communities that must be inclusive of Milwaukee, and not just Milwaukee, but southeastern Wisconsin. And we're now trying to think about rural communities, and we're thinking about other settings that we know is important. We want to bridge the distance and the gap. We want to reduce that gap for a two-way flow of ideas, and then encouraging the support of SMPH faculty, right? And we support our faculty by continuing to give them training. We make sure that what they're focused on is health equity, and in a way that is actually about resilience models versus these deficit models. And I know that talks about financial support from NIH. We're actually working at the national level. I sit on the CTSA, and actually I'm getting ready to do presentations with them to talk about moving from this deficit model of funding into a resilience model of funding. And so we're going to do that. And then the population, you scared me, camera lady, because let me make sure. I really thought she was telling me my time was up, but the population of Milwaukee, we know that 70% of Milwaukee's population is African American and 40% is Wisconsin Latinx. So we know we've got work to do in these communities. We know we've got to really engage these folks. And so that is our goal. That is our initiative. And so what we've been doing is modeling this program at a not only a state level, but a national level. To make sure we do this work. And this is my last slide, I believe. But basically, if you wanted to look at how we're doing our flow, this is it. We start with what we call now, it's not even outreach anymore. It is called engagement. I want to give you a quick definition. Outreach means just reaching your arm out. It's outreach. Engagement means you're putting your whole self into it, and you're staying in the mix with the people. So we do engagement. We don't do outreach anymore. Consult, right? So we're making sure we're going back and forth, consulting with each other, involving, and then collaborating. And then we have shared leadership. Can you say shared leadership?
Shared leadership.
That bi-directional leadership, which means that what we are really making sure of is that the institution is not the hierarchical in the community. Can we say that again? The institution cannot be the hierarchy in the community. What I tell investigators is come on in, sit down, shut up, and pretend like you're a wallfly. That's all you got right now. And if you got some coffee money, bring some coffee money, but don't talk, all right? Don't talk, don't ask, and be a part of listening. You're the listening session this time. The listening session is you. You were the focus group participant. You're learning. That's the first step. And many of you know that, but we all say we know it, but can we do it? And do we do it? And that's what we've got to get our investigators to think about. So that's really important for us. And at this point, I'm going to transition to Dr. Easter, who's going to talk to us about our actual cohort model and our community engaged model at in real time. You want to use the mic?
You need me to stand?
Yeah, you can do that. Of course you've got it. Oh, you can?
That's all right.
You can pull it out.
Nope, that's all right. Go here. So I want everybody to, first, how many of you, Gina, first of all, give Gina a hand. That's a lot of information to try to impact in what, 10 minutes? You did a great job. How many of you in the room know about the All of Us Research Program? All right, let's start there. Program started in 2015 under the Barack Obama administration. The focus is to be able to find a way where we talk about precision medicine. And what is that? What does that mean? It's to be able to enroll 1 million participants to use their data to find medical treatments or procedures individualized to be advanced medical research. What we're realizing regarding this program and to enroll individuals, they're looking about 47% of these individuals to be from underrepresented populations. And then the question is how do you do that? You know, they're looking at individuals 18 and up, and they're also saying you can be well or you can be sick. And I use this analogy regarding it as I started to understand this program is that we have individuals that have glasses on, and some of you may have contacts, and some of you have been blessed with clear and good vision. But I cannot wear your glasses, and you cannot wear mine. They're precise to you and precise to me. And we've been taking medications and doing these treatments that truly were actually tested on middle-aged white men. And so what was happening is if you're asking 47% of individuals who are underrepresented populations to be a part of research, right? And understanding that they have to be a part of this, first you have to give them the reasonings why, but then you have to listen to them, their reasoning why they won't. That's a huge thing that we recognize, that we talk about the issues and the history of the mistreatment of people of color in research, it stays within them. It's not just Tuskegee. There were other things that were done that we're asking for the communities of color to be a part of something to advance our research. And they're not understanding why should they be a part of it. So as I've been being a part of the All of Us research program, I had my own thoughts about what do I believe in and what do I believe in regards to research. One thing I started understanding, and I don't know when it happened, but something clicked. Something clicked. I was out talking about the program because I did believe in regards to more people of color should be a part of research, but it didn't click to me the reason is why, and then it did. This is a national program. We're the 9th state to be a part of this initiative, and what I realized, one thing that I have to say, I've been born and raised in Milwaukee. Wisconsin and Milwaukee, we're in silos. We stay in our own lane and do not look at any other national view except we're asking for money to come here. What I realized once I was able to go to the national program of All of Us, it's not the end all of tell-all, it's not the huge answer to everything, but it is a tool. It provides a process to talk about your DNA. It also provides a process to give you information about your ancestry information, right? So what I started realizing is what is the data that we actually need as people? I want to take the guessing out of my life regarding my health. We all guess on what's wrong with us or what's going on. We go to our doctors, and they're not a part of our team. They do not talk to us as, these are the things that you need to do about yourself. I'm literally waiting for them to tell me what I need to take, what I need to do, but I really don't know about this body that I've been walking around for 46 years. How many of you know about your body? Exactly. How we learned this when I came to the community, it really was very organic. How it was organic, we had a connection, Gina did, to a playwright named Garrett Davis that did a lot of work with the Wisconsin Alzheimer's Institute that talked about issues about Alzheimer's disease, then also talked about the African American community, about prostate cancer, what it's called Daddy's Boys. And during the pandemic, he wasn't able to do the touring. And so he still stayed in contact with Gina and says, hey, I still have these videos, and I've actually put it on a way for you can view it and stream it. And so part of it we were using, it was a event called Daddy Boys that talked about mental health and stress and men of color and black men and prostate cancer. And he does it in a funny way, right? And so we paid for those rights to use that. And so I was in the barbershop, literally, was in the barbershop and saw one of my friends that I knew from years. He's now a pastor. His name is Pastor Locke. And I said, hey, I have a video. I want to see if we can get some men together just to view this video. Then I could give my little speech about All of Us. And then let's see if we can get some people enrolled. Then at that conversation, I met Clem. I knew Clem, Pastor Clem, because we both got an award in 2018.
Yes.
Yep. And in that, I said, hey, we stayed connected. And then I have another gentleman, his name is Robert Jackson, that we stayed connected just because he's part of a group we call the Wolf Pack. And then he's family. Good, I get it. Give it to Clem. So in a second. So in the process, what we did was I said, hey, let's watch this video. We got to the first session and never watched the video. We had community nurses that came in and did the blood pressure checks on the men. Then we did the blood pressure checks on the men, and something clicked as I'm watching them. I asked them, how many of you know what those numbers mean that you did just now, that you got your blood pressure? Only 2 people raised their hand out of 35 men. I said, we have a problem. We're talking about enrolling you in the program or talking about health, and you probably don't have a primary care physician. So we stopped talking about All of Us and start asking them what did they need. So each session became, we're hearing from the men, and now we need to hear from the professionals to come help the men with what they needed. As we started to bring back, we call it the give back, all the resources to them, the men continued to open up. We had our 8th session, that we talk about with the cohort model, we realized that we need to give back to the community. Once they were understood what was the information that they needed, they all started to come in. As you see now, we have a women's group that's kicking off. But what is the information that we're talking about having? So the first thing we're talking about is know your numbers. You need to know your LDLs, your cholesterol. You need to all to know your A1Cs. You need to know all about these different things. But first, they need to understand what all those terms mean. So I was going to the doctor, getting my metabolic panels and my lipid panels, and took the words and put it into Google to understand what it meant. So how do we expect the community to tell them to do better about their health, and they truly don't even understand what they're reading from the doctor? So we're taking a group of people, of men that we have, about maybe 15, to be able to go from the start of health literacy, from understanding their blood panels, to then understanding their snapshot of their DNA. That's our focus, to get them. So we have workshops to be explained to them about. We have a physician, Dr. Kevin Izzard, that actually explains to the men. We also say 3 pillars: mind, body, and spirit. So we started with the body, so we brought in exercise for them at no charge to them to be able to go through 16 weeks of exercise. Then we also have them had a chef come in and did a vegan 5-course meal for them to try, brought them in to be able to try that, which they liked and didn't like in some of the instances, but it was something to expose them to. And then we're focusing on 3 months of that, another 3 months of the mind, another 3 months on the body. On the spirit, to be able to reach them all where they are. And in these partnerships, what I'd like to bring up to Clem is, why did this work? What was resonating with them? He's going to do the 3 months regarding the mind. And what we realize is that the reason why a lot of the men are not coming to the table or not talking about it is because we don't think our health is important first. We think everything else is. And so, Clem, you want to talk about a little bit about the partnerships and what we want to do? Do you need your mic?
No, I'm good. Yes, I'm right here.
Okay.
So thanks for having me, everybody. So what I've seen, just working with the men, just been awesome to come alongside as a partner with Dr. Bashir and everybody that's a part of the organization and all the men. So we're excited about it. That first event, we had about almost 50 men there. So we were excited about that. But it's not about the numbers. It's about just inspiring them to learn about their mind, body, and spirit, right? So I'm going to be talking about, coming up in late May and June and July, the hijack mind. What does the hijack mind or the hijack brain looks like? So I'm a counselor, so I'm going to use some clinical terms. People use drugs and alcohol, and so that it hijacks the brain from learning. And so what happens is it hijacks the mind too, because some of those beliefs and things that a person learns, it impacts their lifestyle, right? Also, they end up, when you use drugs and alcohol, it impacts the mind, where you end up with mental health disabilities or issues, right? So we kind of talk about that. When I did talk about it, I came from a historical, generational trauma perspective. And so I did go back into the 1800s, to the Atlantic slave trade, well, not the 1800s, the Atlantic slave trade, actually, to the here and now. And what's the difference? Even with dealing with the George Floyd incident during COVID 2020, that had a mental impact on a lot of the men that I work with, even with some of them driving, seeing with the guy, the cop with his knee on his neck, continue to see that. When you continue to see that, it really hijacks your mind, because now you're impacted by the trauma. Will that happen to me? Will that happen to my son? The ripple effect behind that, right? So we talked about that. We talked about the Breonna Taylor situation, because everybody was on lockdown during that time. And so anytime that you're dealing with social isolation, you become hijacked in the home. You become hijacked mentally. So I was telling Dr. Bashir how a lot of the men was dealing with depression, and even if they don't turn to drugs and alcohol, because they don't want to just deal with life, living life on life's terms. So those are some of the things that dealing with the hijacked mind. And in those areas where I grew up, in the 53206 zip code, I grew up around the A.O. Smith, where there was factories. So people in those areas where I grew up, and you're dealing with the pollution, you're dealing with the freeways in those areas, you're dealing with the food deserts, where there's not enough good quality, healthy foods to eat. And so people turn to the foods that's in the neighborhood, which is usually the corner stores. And with that impacts the mindset too as well. So now you think that you don't have any choice but to turn to some negativity. So then I'm going to talk about the man and the environment. Those environmental factors plays a big important part too as well. What do I mean by the environment? the life expectancy for someone who lives in Brookfield is a lot longer compared to someone who resides in Milwaukee County. Why is that? Well, the violence, drugs that flood the community, poor schooling, overdiagnosing Black and brown Latino kids and underdiagnosing, right? So those are some environmental factors that's definitely impacted. Single family homes where the mom has to do what she needs to do to take care of the kid, but there's no father in the home or no father who's co-parenting, right? So so we talked about that and dealing with those issues, and also the man and the social factors. Some of the social factors are the racism. I believe they had, I think it was a couple of years, ably, the number one public crisis is the racism, is a public health crisis. And we talk about the systemic issues that's in the institutions, that's into school, that's into capitalism and all that, making money off people's misery. So we kind of just, those are some of the highlights right there. So definitely going to be looking forward to talking with some of the men. Some of the men were shocked by that, right, Doc? Mm-hmm. I would just share the information, because a lot of time when you hear truth, it kind of, people kind of take it back. Whoa, hold up. Is this real? Yes, it's real. It's real time. What would make a man take his kids and dump them in Northridge water and drown each one of his children? You got to have a psychological issue that's going on, all right? And so just talking about some of those things. Also, some of the solutions that we're definitely going to bring to the table when we talk about our men's talk is create opportunities. We're not looking for a handout. We're looking for a hand up. So those are some of the opportunities. Provide equal access to health care. If you want to see people get better, providing access to health care is really definitely key. A lot of the men that I talk to, they might not talk in the group, but in the individual session, they would definitely talk and share and open up and share the pain that they're going through, whether they have a hijacked mind or a hijacked environmental situation. And also, we need to invest in the low-income neighborhoods where they were distressed, the resources were taken out, and drugs were put in. Okay, just the books were taken out, and all of a sudden guns are put in. How can a little kid find a new gun but can't find a new school book? It's just the same way if we go into the suburbs. If I take out all the resources but put all the drugs in there, what will happen to the suburbs? Mm-hmm. See, so we have to come from a different perspective. So that was my take on it.
Thank you.
You're welcome.
The last part of what to share, give him a hand, please. I think we thank him because he's a partner, and when he came in as a partner, it was no money involved, as Gina stated. He stated in regards to it how he can be able to provide the services as we built that relationship and continue on. But one of the things we did want to make sure, as we did when we talked to community, having individuals a part of research is important. So we immediately talk about what we can give back to the community, but we also let them know you need to be a part of research. And so our recruiting is to say, you are not just give your essence and walk away. The goal is to say you are a partner. We say once you are a part of the research, you are a part of the research. You're giving us information. We have a community advisory board, a participant advisory board that our staff is working on to be able to continue to build. And what we're making sure is to understand that is that we need you to be in the forefront, not just with the white coats, but individuals as a pipeline to be the researchers, to be the scientists, to be the doctors, that you can do so and take a hold of the research as being very important. So we actively recruit. We actively ask individuals to be a part of research, but we ask them to do their own understanding and study before they actually come on board with the All of Us program. And we're very upfront to say what it is and what it isn't, right? And we let them know that nationally. So that's one thing we continue to do, not just about the All of Us program, but also with the work with the RAP study. So we are doing collaborations to make sure that there are other research programs or studies that you can take a look at. But also the goal is we look at a process called community scientists. There's a workbench that all of us actually is going to have, that this data is going to be able to be accessed. So we're trying to build the community to be just that. The community scientists to use this data so you understand it at the ground level from where you are. As Pastor Clem stated, 53206 is a major area of issues, right? So what we were trying to see is as we build this community scientists of novice people to understand how to use the data that they will also be a part of. So that's another goal that we're looking to do as we're trying to change the model from individual researchers and scientists to just come to the community. The community are now going to the researchers and telling them, these are our issues, how do you help us? I know that was a lot. Go ahead.
No, that's great.
That's good.
That's absolutely great. And I do want to say this, and I just have to stand because I'm old school, y'all. I'm in my 50s. Don't tell nobody. My kids don't know. But what I want to say is, so many of you probably are like, well, how does this go back to what you said earlier, Gina? And if you were to look at our old slides, and if we were to go back a few slides, when we look at this model, that's exactly what you just heard. What we are committed to doing, as Dr. Easter said and Pastor Clem have said, is we're meeting the community where they are before we actually start engaging in enrollment and research. Without having these built relationships, and Dr. Easter can talk about it, and so can Dr. McAbee, we would not be able to recruit at the numbers that we do. So we have spent time with this men's study group, and that's just one group, right? We have spent time with them, and as a result, when we had an enrollment session 2 weeks ago now?
2 weeks ago.
2 weeks ago, the gates were flooded with people enrolling. Now, part of that means we know that's not a one and done for us. What you're hearing is a continuation, and it's a continuum. So though they've enrolled in the All of Us research program, as Bashir said, we're giving back. So that means we're going to do health literacy. We're talking with other scientists about saying, how do we make sure that even though you're enrolled in this All of Us research program, as you're getting your results back from All of Us research, if you're getting questions that you don't ask, guess who the resource is? We are. We're going to bring information back to you. It is more important to us, let me just be very transparent, it's more important to me that we are helping these black men, quite frankly, improve their health outcomes and have longevity than it is for me to ask them to enroll in research. Research is secondary, human interest is primary. Okay? That's really what our model is. And so with that, I think I'm about 15 minutes out. I want to make sure we get time for you guys to have questions. We have tons of stuff to talk about, but can you see this model in real time? This is a new, I'll say it's a different model. It's not the traditional hierarchical model where people are just coming down and just saying, here's the research,
right.
Join us, love us, be with us, and then we get our data and leave. That's not the model anymore. That's not the model we want. What we want is to be integrated into these communities through our work. We want to make sure these folks, again, if all the money leaves, God forbid, if NIH decides not to put any more money, we have left the community better than when we came. We've left something that makes them whole. Does that make sense to everyone? All right, I wanted to kind of close with that. And if you wanted to say something else, sir, I will lend the floor. So what we'll do is we'll open up for questions and answers, and we'll do some Q&A right now. And if no one has questions, we'll just keep talking. Thank you.
Hi, I'm Alicia. I'm in Chippewa Falls, originally from Milwaukee. Ghetto girl. Do what I do for a reason. So thank you all for doing what you're doing. But I started with All of Us a couple years ago, and then COVID hit. So when I was just starting to make that momentum, I kind of lost it. And in our area, it's all about being able to access the information online, creating everything online. We're in a rural community, low education, low income, and they don't have those resources. So how do we reach those people and get them on board?
Want to talk about it?
Yeah, so we are recognizing that. I will be very transparent to say we told even the NIH, I actually sit as a co-lead for engagement and retention at the NIH level. And so we let them know that this program is named All of Us, but we're only reaching some of us. We know there's a digital divide with a lot of individuals in community and rural, and then even the language is to be able to reach, making sure we're reaching everyone in language. And what we've done is we made sure that one of the things that we are trying to do is that individuals, we actually meet them. We don't just do everything online, right? We actually have a clinic that we have individuals that they can come to, or we go to them. The partners help us with that. So that's the other thing is, so Pastor Robert Jackson, Clem, and actually Pastor Locke, their facilities opens up so as to bring our laptops, our computers. We sit with them. I would give a big shout out to Dr. McAbee. We had our event. There were individuals that came in that have to start from the beginning. And when we say this is about a 3-hour session, you all, we encourage individuals to do things online, but the individuals are coming in like, I didn't know how to do all that. You have to have an email address. We actually get the individuals set up with their own email address probably for the first time. We sit down and we make sure they understand everything they're looking at before they move forward. If they don't, we don't allow them to move forward, right? So we bring them the technology. We sit with them, right? Because we understand that we're going to miss. So using the facility, like what's already existing, libraries, right? So certain places that are there that the community already frequents, we bring our equipment there to meet them where they are when they're interested. Does that answer a little bit of it? Yeah, we're very aware of that.
Yeah, and we are part of the cohort that is Marshfield.
Yep.
And of course, UW-Madison has a site, and then we're UW-Madison placed in Milwaukee area, right? So we're one site, 2 locations, and then the medical college. And so to your point, we're actually working, our Madison team is actually working with the rural communities to actually do simulate and replicate what we're doing. We're working on them to get better at it. Let me just be transparent if I'm being recorded, but it's okay. They know I tell the truth. We're getting better at that, yes. Go.
You guys bring a different energy. And I think after 2 years of isolation, people need that.
Mm-hmm.
And thank you for getting them inspired up a little more.
Thank you so much. Our pleasure.
Hi, I'm Travelle Ellis. I'm a director of health equity at Exact Sciences and alumni of the University of Wisconsin School of Medicine and Public Health. My question actually segues nicely with Dr. Gina was talking about. How do we get the ivory tower to change? Can you talk through some of the strategies of changing hearts and minds to sit and listen and not push numbers or think of these individuals as data points, but actually people who, this intervention is going to take a while, and we are investing in their livelihood?
That is an excellent question. Can I take another sip? Actually, I'm going to point to Dr. Yinka, and Dr. Olayinka Shabiola is really her name, but Dr. Yinka is an excellent example of a scientist who really had a passion for coming out of the ivory tower and into the community, but needed some tools to do so. Not because her heart wasn't right, but because she needed some tools to come in the community. And what she's been able to do, I think the last, how many years now we've been working together? Almost 8 years. Yeah, to your point, it was getting another investigator who could champion for you, right? So when Dr. Yinka had the passion, we helped her with the tools. She came to our community advisory boards. She began to get entrenched in the community partners, and we started going to different churches together and really introducing her to folks. But what that did is it gave her the tools to go back to her colleagues and began to say, hey guys, the way we're doing research in this top-down method is not going to be sustainable. It's not going to work. So that's the first thing, I think, finding a champion who can actually talk for you when you can't talk. Because you guys know investigators talk to investigators, just like doctors talk to doctors. And so the reality is that once we started getting champions like Dr. Yinka, then we start hearing other people say, well, we want to do this research. How do we get into the community? Again, it's a long journey. I'm not telling you guys it's overnight. It is a long journey. It's really also letting people fail. I shouldn't probably say that publicly, but it's true. One of the researchers that I worked closely with for well over since I started the institution, which is about 13 years, wrote a huge grant to NIH, and she wanted to expand her rural program into the urban setting, and she totally, exactly what you're talking about. She had a mental mindset that, oh, it doesn't matter, it's just another city. And I kept trying to remind her, no, you need to go to the people first. You need to not, this is not a cookie cutter approach. And so what it took was her not to get her grant funded. She didn't score, and she had to go back and revise. And so that investigator then came and said, hey, can you help a sister out? And we did, but it was those kind of aha moments. And then my third thing is funding from the NIH. Forcing NIH, or not forcing, but encouraging NIH to really rethink its funding rubric. And what I've been saying to those higher up folks is think of it this way. If you, because people follow dollars, it just is. When you think about how funding works at NIH, It's really, we get to be reviewed, and we get scored, and we get funded, or maybe not funded, right? But what if, think about this, you guys, what if part of the review process actually included community, real live community members? I'm not talking about people like us, that's community. I'm talking about people like Pastor Clem, who's real community. And the question that the reviewer would have to answer is, give me 3 primary ways in which this investigator has worked with you to resolve issues in your community prior to funding. And that would be tied to your funding.
It got quiet.
Right.
A little quiet there.
Imagine that.
Crickets.
Do you know how much of a difference that would make? If your scoring was based on that question and you had no answer, and your funding was based on that, imagine the difference in how investigators would come off those ivory towers. The other thing we have a problem with is that we tend to tell the story of success through the lenses of our institutions. That community advisory board was fantastic. The community advisory board said, did you interview them? I mean, why aren't they saying it to us directly, right? What I have found, and I've been doing, so my research, just full disclosure, is around community advisory boards and from the view of the average community member who served on a CAB. The literature is sparse from the voice of the people. So that's another thing that we have. So those are my 4 points, right? You need a champion. You need to make sure that you are letting sometimes people who don't listen to actually experience a little failure. The third thing is think about, we got to keep working at NIH and hold them accountable for how they're funding. And then the fourth piece is to really understand the view of the community and start working in those areas. And so I would encourage all of us in here, as we are community folks, as we are really interested in the voice of the community, because I believe you all are, it's really also helping our community members become part of community science, helping them understand that they are experts in their own right. Who know, if I were to ask you, were you a health expert, how many health experts are in here? Okay. How many of you know your body the best? How many of you know your health status the best? I mean, put your hands up. On some level, guess what? You're an expert. And that's what I try to get researchers to understand. The community, you don't have to tell us diabetes is in the community. I can look at Uncle Joe and Uncle Bubba and Bobby Sue to see that, because they all are legless. I'm serious. I mean, and that's the other thing. We've got to get people comfortable with telling the truth and really allowing for community to be heard and voiced. Did I answer your question? All right. Yes. Other questions? Yes. Perfect.
Hi, Julie from Carn. You guys kind of know me, but your presentation was excellent. And I just have a question. You mentioned Wisconsin's the 9th state to come into All of Us, the All of Us study. Are the other 8 states modeling your program model and really learning from the experience of Wisconsin?
So we are going to have a conversation with our Chief Engagement Officer. His name is?
Don't bump your head.
Sorry. Yeah, Dr. Kareem Watson. Yeah, I knew his name. I was just playing.
I forget
yeah. But in that, we are letting them know how this looks. So we get to present. All the different consortium groups across the different states are presenting their model of retention, recruiting, in regards to engaging the community as well. So we get to actually share our models, and we're excited to do that. That's going to be in June. The whole consortium group will be able to do that. And we'd like to say thank you, Karen, for being a part of this effort that we are doing, and with the men and the women's, because Karen is also a part of the partnerships to be able to make sure we're able to sponsor some of these events that are going on as well. So I want that to be known. But yes, so our goal is to share. Our goal is to be able to make sure that they know what's going on in Milwaukee. And again, it's not a cookie cutter approach. We want to make sure that they understand how this works. And then we also share with the other consortium groups to say, how does this fit into your community and your cities as well?
And Bashir's given a really nice answer, but I will say yes. I believe that our model is going to be replicated across the country. I believe that. They've asked us, we did a series on addressing racism, systemic racism, a webinar. They wanted to know how we did that. They brought us to the national level to talk about that. And not that we're the only model that will be replicated, but what I think is that we're demonstrating excellence and results. And again, I will say this, and Bashir and I will be the first to admit, I'm not as up on the numbers, but I would tend to believe that we're probably one of the few states that actually have these cohort models.
We are the only.
And the only one that has a large cohort of black men.
That's great.
That's good.
In the country. And so I do believe, and I think others are coming, I do believe we have something that's worth replicating. And so that's why it's so important for us to make sure that we're sticking to this model, we're testing the model, and we're wanting to make sure that it will be evidence-based, evidence-informed, all those other evidences you want to put in there, right? We want to make sure that it's replicable across this country, because we believe that this is a tool that actually can change our health in our communities overall. So I just needed to say that. Thank you. Yes, ma'am. You got to wait for the mic, though, Miss Martha.
A little bit more about trust. So as an individual, I could build trust, with another individual, but someday I won't be in this job, right? Someday I'm going to move on and someone else will be in that job. So how do you build the trust between, my employer, the big organization that I work for, and an individual group?
So one of the biggest things that we make sure that as we build the pipeline, people have to look like the people in the community. That is huge. But that's not the only thing, right? It's not just the way you look, it's how you actually bring to the community. What are you doing first for them? I think that started immediately. And I would tell you, me and Clint were having this discussion about the men, and I've known some of the men that are part of this, the sample group for years. And as I'm bringing this to them, know the kids, family, all of that, they still didn't trust me because it was new. They even asking, was Basher getting paid for this? Right? So when we're saying that, we want to make people understand that we're doing this because we want to see the change. I believe in the community has all the equipment, the understanding to make the change. I want to bring, as Gina talks about, bring the resources to them to do it on their own. We are looking for light bulbs. So some of the other things we're bringing to keep sustainability in the community, we're using their technology, working with institutions that are having the technology that is left with the community to use once all of us is gone. They understand the process. They understand what it looks like. It is not me talking about it anymore. Now the community is buzzing about what's going on. Some of the things that they're recognizing is, I understand what cholesterol means now. And I'll say this really quick. The other thing is, once the men understood what the top number means and what the bottom number means, and that's what I'm saying in those terms, because that's what they understood, about their heart and about what blood pressure actually means, when the heart is pumping and when the heart rests. All you saw were light bulbs. Started to understand. Now I get, if the bottom number is that, and it's not resting, now I need to be concerned. And so Nurse Julia Means said that in such a terms that the men understood. They went back to get checked again. Now they're asking to say, I need to know my numbers, because they understand. And I will give this to the women. I have to share this. And the men, please, want to close your ears, how we feel, because we all are in the same boat. You lead us in regards to health. You tell us. Us men feel like we need to work, we need to provide, and then we need to love, and we're done. We do not think of ourselves. And if we're not well, we're not doing all the things we say we want to do. But you, as women, push. The women's group were twice the size of the men's group. You understand the importance of that. You understand that, but we need for you to tell us you need to do this on your own.
And I know we're probably at time, but what I do want to say to your question too, thank you, Dr. Easter, is this. The one biggest thing your institution can do is take a look at its past record and relationship and apologize. If you're, one of the biggest things that we had to do, at least when I started, so when I started the UW in 2008, working for the Wisconsin Alzheimer's Institute, and we were doing Alzheimer's at that time, and the community completely wasn't ready for Alzheimer's, but they were less ready for the University of Wisconsin-Madison to come to Milwaukee, and that's because of helicopter syndrome that was happening. What I had to do was take the responsibility, like Bashir said, they didn't trust me either, because I work for UW-Madison, but what I had to do was get the apologies out and come back and say, we blew it, we did it wrong, but if you trust me, not today, but if you allow me to build my trust over time, I commit to you, we will meet you where you are. And I began to bring my bosses, the dean would come out, everybody who you could think of, I brought into the community at FACE to really talk about where we were. We held programs, we offered resources, we did it over, and we asked for a do-over, and the community actually allowed for that. But again, remember what I said, if I say something, I have to do it. And with that, I want to stop there. Thank you guys so much. We appreciate you. Thank you for allowing us to be here.
Thank you so much for that wonderful presentation. I don't know about you, but like I feel like a whole new level of energy has just been like spread out in this room and ready to go for the rest of the afternoon. So lots of takeaways about community engagement and the right way to do it. So I hope you will be able to take those away and implement them. So thank you again very much, and we're on to lunch. Thank you.
All right. Okay.